Great, thanks everyone. I'm Jyoti Patel. I'm so pleased to welcome you to Grand Rounds today, where we're really highlighting the great work that our fellows are doing. As a reminder for CME credit, text 56774 to the CME number, and we'll kick it off. I'm thrilled to introduce Dr. Lauren Chiec, who has really been just terrific and has been one of our chief fellows in our division. Lauren is an Ohio native. She graduated from medical school at the University of Cincinnati, and we've been thrilled to have her here at Northwestern since 2015. Since 2015, she has had a consistent track record of just outstanding clinical care, deep funds of knowledge and compassion. She completed a fellowship in hospice and palliative care, and then has joined our program as a fellow in hematology and oncology in 2019. At Northwestern, she's won the Webster Award as a resident, and it was really, that's awarded by the chief medical residents for the senior resident who best emulates the qualities that Dr. Webster displayed of being a gifted clinician, teacher, and humanitarian. This year, she also was recognized by the Women's Board with the Marakuni Compassionate Care Award, again, really exemplifying a role model who demonstrates humanistic and compassionate care of cancer patients. I've been thrilled to have her in clinics and been working with her as she's really honed some of these traits and her training to develop a passion, I think, for supportive care and lung cancer and geriatric oncology. So with that, Dr. Chiec.
Thank you so much for that wonderful introduction. Thank you everyone for joining us today. I'm really excited to kind of share a little bit about supportive and geriatric oncology. In a short time, we'll do a brief overview of kind of where we've been and where I hope we're going. So let's see here. So I have no financial disclosures. And throughout the talk, I really want to focus on a little bit of the data, the guidelines around supportive and geriatric oncology measures for our patients with cancer. We'll talk a little bit about the barriers to implementation of those measures and hopefully some future steps and potential solutions to improve delivery of these interventions for our patients. So I think we all know that we are in this era of personalized medicine. We've really gone in oncology from this traditional model of treating patients with a few tools in our toolbox, simply based on the stage of their disease, to having so much more at our disposal, being able to recognize patients based on the biology of their disease and treat them based on the molecular markers of their disease, taking into account the personal factors that they bring with their diagnosis. And we really have so many more tools at our disposal. We're using things like targeted therapies, immunotherapies, and most recently, cellular therapies. And this is something that's getting press, not only within the medical system, but also kind of in the lay media. And as the Washington Post earlier this year said, cancer treatment of tomorrow is personalized. And in a Nature review earlier this year, precision oncology isn't on its way, it's already here. And I think nowhere is this more evident than in patients with metastatic lung cancer, and particularly patients with metastatic adenocarcinoma. And what you can see here is that over the course of the past, 10 or even 15 years, we've had significant improvements and many more therapies approved by the FDA for treatments with metastatic lung cancer. Back in before 2010, we really had one targeted therapy and a few chemotherapy options. And since that time, we've really seen an amazing explosion of therapies with targeted therapies, the advent of immunotherapy, which has been, a game changer for our patients. And even since this was published early in 2021, we've had several new approvals by the FDA in targeted areas that were never previously thought possible, and things like KRAS mutations and EGFR exon 20. And so I think, when we're in this era where we're talking about really personalizing care for our patients, I think it's really important to also think about how can we personalize supportive oncology? How can we target our interventions to the right patients at the right time in their cancer journey? So what is supportive oncology? I think everyone here is aware of the fact that palliative care and hospice care are different, that palliative care really encompasses care for patients throughout the course of their serious illness. But I also think supportive oncology really encompasses many other disciplines and really cares for our patients with early stage disease, throughout the course of their illness as well. And I think when I think of supportive oncology, it's not just one intervention. It's not just how can supportive oncology help our patients, but it's really how can all of these different interventions be used and be targeted for the right patients at the right time. There's a lot of overlap between these interventions, but really we know that every individual patient will have different needs. And we also want to balance the burden of these, of coming in for care and of having access to these with the benefit that they provide for our patients. I think we all know that the palliative care is helpful for our patients. Anyone who has kind of worked with the team and has had patients interact with them knows this, but we've also seen this in early studies that patients who have specialist palliative care involvement have improved things like quality of life, satisfaction with their care, symptom management, and goal concordant care at the end of life. But we also know that there's a lot of limitations and a lot of variability in these studies and really in what palliative care means for each patient. So I'll start with the kind of landmark trial that I think everyone is aware of by Dr. Temmel and colleagues from 2010, which really was the first trial to look at a first randomized trial to look at patients with newly diagnosed metastatic lung cancer and randomize them to receive either early palliative care, provided monthly visits with a palliative care provider and nurse practitioner, compared to standard oncology care alone. Their primary outcome in this trial was really looking at quality of life. So they looked at a patient-reported outcome scale, the FACT-L scale, in particular the functional and physical subsets of that scale, in combination with a lung cancer subscale that looked at symptoms that are common in our patients with lung cancer. And they were able to show that there was an improvement in quality of life in the group of patients that received early palliative care compared to the standard care arm, who overall had a decrease in their quality of life. This was before, this was 10 years ago, 12, 11 years ago. So I think this was before the advent of all of these new targeted therapies that we've discussed. So only 6 patients in each group were really on targeted therapies and none were on immunotherapy. But I think even more thought provocatively, we've seen that patients who were in the early palliative care arm lived longer than patients who were in the standard of care arm, with a median overall survival of 11.6 months compared to 8.9 months in the standard of care arm. The average age for patients in this study was 65. And we know that the palliative care intervention was really focused on our standard palliative care guidelines. So goals of care, symptom management, care coordination. And so I think as much as this is a really thought-provoking study that everyone's been really excited about, we also have to think about how can we generalize the study to other patients? How can we generalize to other disease types? And really, how do we think about the study in the era now of really targeted and personalized therapy? In a similar study also by Dr. Temmel and colleagues, they looked at patients who were newly diagnosed with both incurable lung cancers as well as GI cancers. And they were able to show that there was an improvement in quality of life at 12 weeks. More patients who received early palliative care reported discussing their end-of-life care wishes with their oncologist. But interestingly, when they looked at the patients with lung cancer compared to those with GI cancers, they saw some differences. And I think here you can see on the right, in A, you can see this is the quality of life scores for patients with lung cancer. And in the early palliative care arm, you can see a steady increase in their quality of life scores up to week 24. And in the standard of care arm, there was a decrease. This is in comparison to the GI group, where you really don't see that same pattern, where you see patients in the early palliative care arm had about stable quality of life, and the patients in the usual care arm had a slight decrease. The similar patterns were seen in patients with their depression scores as well. And I think what this study really highlights is that there are differences, even within patients with metastatic cancer, in their needs, in the timing of those needs, and in what interventions are most helpful for them. And I think really spurs additional discussion about that. In an analysis of the initial Temmel study that looked at the impact of their palliative care intervention based on age, they really looked at the impact based on quality of care and mood outcomes varied by patients' age. And what you can see here is that in patients who were younger than age 65, those who received early palliative care, again, had a steady improvement in their quality of life score over time. And those in the standard of care arm had a decrease. But on the right, you can see that patients who were over 65 didn't seem to have the same magnitude of benefit as the patients who were younger. Again, making us question, different patients with different phenotypes may have different needs and benefit from different targeted interventions with respect to supportive care. So thinking about our older patient population, I think it's important to think of how we can incorporate geriatric oncology as part of our supportive oncology regimen. We know that there is a lot of overlap with our supportive oncology and our palliative care teams and what interventions they provide to patients, but we also know that older patients have really unique needs. They have comorbidities, we need to address things like polypharmacy, they may have higher rates of things like cachexia. So although there's overlap, there's also very specific needs for our geriatric patients. And we know that our cancer patient population is aging. We know that a quarter of patients who are diagnosed with cancers every year are over age 65, and that patients over 70 make up 50% of our cancer diagnoses total patients every year. And we also know that our guidelines really recommend that we incorporate geriatric screening for older patients who are being considered for therapies. Both geriatric screening tools as well as more comprehensive assessments are recommended both by the NCCN and the ASCO guidelines. This is from the NCCN guidelines, but again, just kind of noting that we have a variety of geriatric screening tools that have been validated for our patients with cancer. Most of these tools are tools that can be completed relatively quickly, but uptake into routine care has really been slow. We haven't seen a routine uptake. And I think there's a lot of barriers to that. I think we all know that time in clinic is valuable and it's challenging to implement new interventions. I think education and really understanding the value of these tools is limited. And I think, just really understanding the impact of these in prospective studies, the data has been really limited. And so understanding when to use these and for which patients is still a little bit unclear. For those who aren't familiar with the comprehensive geriatric assessment, I want to at least mention what components we think about when we're assessing our older patients with cancer. And when we're talking about older patients, I think it's also important to kind of define what that means. In a lot of the studies, over age 65 is what's considered a geriatric patient, mostly because that's the age of Medicare. In a lot of our lung cancer studies, we think of patients who are over 70, which is the median age of diagnosis. The comprehensive assessment really looks at functional status, it looks at cognition, mental health, nutrition, a variety of other factors that really are not able to be assessed just in an oncology visit alone. And although our data is limited, we do know that for patients with cancer, implementing geriatric assessment improves satisfaction. It increases the discussion about aging-related concerns and improves the quality of those discussions. But prospective data about outcomes for patients is really limited. So I think that this is a really nice framework as we think about how we care for our older patients with cancer. And we know that all of our patients really come to their diagnosis bringing their own backgrounds, their own social backgrounds, their own medical backgrounds and histories. And they have unique needs, both from a geriatric and a palliative care perspective. Those needs have a lot of overlap, but there's definitely needs that are unique to each specialty that should be addressed, particularly for this patient population. And as we think about that, all of those different factors really should influence decision-making for patients who are older with cancer. And then we think about how does all of that impact outcomes? When we're thinking about outcomes for older patients, we're thinking about end-of-life care, functional outcomes and quality of life, things like symptom management, as well as overall treatment outcomes, particularly as patients are living longer with our newer cancer therapies, things like immunotherapy, where we're seeing patients with overall survivals really with durable responses. So I want to focus initially on how we can think about improving end-of-life care and advanced care planning for our patients. We know that advanced care planning is important. We know that it's associated with improved quality of life, communication with providers, decreased burden for caregivers, which is especially important for our older patient population, and an increased likelihood of patients receiving the care they want at the end of life. Interventions focused on advanced care planning have really been recommended to be implemented in a systematic way by a variety of different guidelines. But we know that just like there are barriers to implementing geriatric assessments, there are barriers to implementing advanced care planning interventions as well. So I want to briefly talk about a project that I've been really lucky to be involved with here at Northwestern, which is the PACT Conversation Trigger Tool. And essentially what the premise of this project was really to create a tool that could be used to identify patients at the time of hospitalization who can benefit from early advanced care planning interventions. This is a tool that was created with consensus input from 10 palliative care physicians with expertise in this area based on guidelines for consulting palliative care. And ultimately, the tool was implemented in 10 sites throughout Illinois. What I'm going to talk about is the initial implementation of the tool, where we were focused on looking at the reliability, the acceptability into the workflow, as well as the internal validity here at Northwestern. So here's the tool and what it looks like. Ultimately, the tool encompasses markers of serious illness or comorbidities for our patients, as well as markers of functional decline, which you can see here in the bottom three, things like frequent admissions, decline in function, or patients who are requiring a lot of care outside of the hospital. Patients who scored 3 or higher were considered positive on the tool. And the reason 3 or higher was chosen was because that included at least usually one marker of a serious illness or one comorbidity, as well as one marker of a functional decline, which is often what would make sense for a palliative care team to be involved. Patients were screened with the tool over the course of 6 months with a longer term goal of implementing additional conversations with champions who were provided education about how to have these conversations to hopefully improve outcomes for patients. We initially looked at the validity here at Northwestern, so we implemented this on our solid tumor oncology unit where we screened 135 patients over the course of 6 months. 40 of those patients, or 30%, triggered positive using the tool. And what we were able to show was that patients who triggered positive were more likely to have a DNR order on that initial admission, and they were more likely to have a palliative care consult. And of the patients who triggered positive, 35% of those patients died or were discharged with hospice on that initial admission, compared to 6% in the group that did not trigger positive. Ultimately showing that our tool is really identifying patients who were sicker and had increased morbidity. Our initial thought was hopefully we can use this to increase early advanced care planning. But I think what we're finding is that we're really identifying patients who may benefit from more urgent goals of care conversations. Ultimately, we were able to show that the patients who triggered positive with a score had a decrease or had a lower overall survival time compared to the patients who didn't trigger positive, again, suggesting that we are identifying patients who are sicker and can benefit from this intervention, especially when we have limited resources. So going back to the framework of how we care for our older patients with cancer, I want to talk a little bit about how we can think about outcomes for them, particularly with respect to function, quality of life. We know that patient-reported outcomes are prognostic for our patients with cancer. There's been many studies that have shown this, and here highlighted is just a meta-analysis looking at 16 of the randomized trials that included patient-reported outcomes, specifically with the physical functioning subscale that we know is most prognostic for our patients. And what you can see here, kind of in summary, is that all of these studies shown that patient-reported outcomes are prognostic and predictive as far as survival for our patients. So for every 10-point decrease on a scale for quality of life, there was a 12% increase in the risk of death for patients. And in addition to being prognostic, studies have also shown that patient-reported outcomes can or may impact survival. And so here is shown is a randomized controlled trial that looked at patients who were with metastatic cancer who were initiating chemotherapy. And they were randomly assigned to receive either usual care or a web-based monitoring of patient-reported outcomes, which was really looking at 12 common symptoms based on our NCI guidelines for adverse events. Their primary outcome was looking at health-related quality of life, and they were able to show that there was an improvement in quality of life at 6 months. But in a post-hoc analysis for overall survival, I think intriguingly, they were able to show that their overall survival for patients who underwent patient-reported symptom monitoring was higher than the patients in the usual care arm. Why this is, I think, requires additional study. Some thoughts are that potentially as we identify and treat symptoms earlier, we prevent long-term complications, or potentially we allow patients to continue to receive cancer-directed therapy for longer periods. But nonetheless, I think is a very thought-provoking study. Similarly, in lung cancer, a randomized trial of patients with both early stage and metastatic disease that was non-progressive, patients were randomized to a similar intervention. And in this study, their primary outcome really was overall survival at 2 years. And again, they were able to show that the overall survival for patients with the web-based monitoring was significantly higher than the patients in the control arm. Again, suggesting that really patient-reported outcomes give us a way to really identify the needs of our specific patients, to really target interventions to them when they need them in their cancer journey. And I think really suggests that including these in our clinical trials as outcomes and really thinking more about how we include these is important. So again, kind of going back to the framework, I want to talk a little bit about our older patients and their specific geriatric needs. We know that geriatric screening tools, again, are predictive and prognostic for our patients, and specifically with respect to predicting chemotherapy toxicity, these have been shown to be beneficial. And we know that they most likely will help us to influence treatment decision-making when implemented. But despite numerous publications looking at the value of these tools, prospective evidence about how to best utilize them and implement them in practice is really limited. In 2021, we know that the standard of care for patients with early stage non-small cell lung cancer is really evolving. The Pacific trial showed us that for patients with stage 3 or unresectable lung cancer, the addition of durvalumab, a PD-L1 inhibitor after concurrent chemoradiation, improved overall survival for patients. And more recently, this summer, with the IMpower 010 study, we saw that patients who underwent resection for their early stage disease, for stage 2 and 3 disease with high PD-L1 scores, had a significant improvement in their progression-free survival with the addition of a year of atezolizumab after therapy. There are numerous trials that are ongoing, looking at neoadjuvant immunotherapy and immunotherapy in various settings for our patients. But we also know that in a lot of these trials, our older patients are really underrepresented. And the patients that are in the trials tend to represent the fittest of the fit. Looking back to the Pacific trial of durvalumab for our patients after chemoradiation, only 22% of patients in the trial were over 70, and only 8% were over 75. And when we looked at the benefit of durvalumab stratified by age, although we did see that the benefit exists for patients who are over 70, the magnitude of benefit did seem to be less compared to the patients who are less than 70. In addition, we see that there are higher rates of grade 3 and 4 toxicity and higher rates of serious adverse events in our patients who are over 70. And so that brings me to a study that I'm really excited about and hoping to implement here soon, which is looking at the feasibility of how we can implement geriatric screening and assessment for patients with early stage non-small cell lung cancer being treated with curative intent immunotherapy, which here means durvalumab after chemoradiation or atezolizumab after surgery, which we anticipate to be approved in the near future. Preliminarily, we're planning to look retrospectively at our own data of patients here receiving durvalumab with a focus on rates of toxicity and early discontinuation based on age. Ultimately, patients will be screened with what is the G8 questionnaire, which has been validated in patients with lung cancer. So all of our patients over age 70 will be screened with this tool if they're being considered for curative intent immunotherapy. And you can see that the tool includes 8 markers, all of which are very easily obtained in a clinic setting. It takes less than 5 minutes. And the only question that really requires you to kind of ask the patient specifically is one here where we're asking patients how they rate their health compared to other patients of the same age. If patients score less than 14, which is which has been validated as the trigger for referral for a more comprehensive assessment, they will be referred for that assessment in partnership with our geriatric and geriatrician colleagues, and they will complete subsequent assessments at 3, 6, and 12 months. Here is just the comprehensive geriatric assessment, what we will be including in that for the study. And again, as this is a feasibility study, our primary outcome will really look at the proportion of patients we're able to screen with the tool to hopefully allow us to identify barriers to implementation. Secondarily, we'll look at the number of patients who get referred for and appropriately complete their assessments. We'll look at a validated acceptability survey, as well as the association between scores on their screening tools and their assessments with rates of toxicity, early discontinuation of immunotherapy, and overall survival. As an exploratory outcome, we'll hope to compare these groups to a retrospective group with respect to the same outcomes. So going back to this framework here, I think all of this is really, a rapidly changing field where we have a lot of needs for our patients. And thinking about the treatment outcomes at the end of the day, we are having very different conversations with patients than we were years ago. Patients are living longer and there's a lot more uncertainty about outcomes with care. And so as that is happening, I think all of our interventions should really also include treatment outcomes such as things like toxicity, discontinuation of care, and ultimately survival. And as far as future directions, I think things like collaborative care models, how can we incorporate palliative and geriatric care together, as well as the vast variety of supportive oncology options, improving education for our primary providers, our oncologists, to be able to implement some of these on their own before referring for additional care, really focusing our clinical trial outcomes and making sure that we're including key outcomes that are important to our patients and being more inclusive of our older patients in clinical trials. Ultimately, what this means is that we will be focusing on things like implementation. How can we find the patients and implement screening tools that we know will be able to be integrated into our care, targeting our interventions to the right patients at the right time in their disease course, using all of this information to really inform decision-making, and ultimately assessing the impact for our patients on outcomes. So in summary, I think supportive care is really evolving just as cancer care is evolving, and I think we really need to be focused on targeting our supportive and geriatric interventions to our patients at the right time in their cancer journey. Despite a lot of data about the prognostic value of screening tools, really implementation has not been universal, and really limited data exists about the impact of these interventions on our patients. And so I think this really represents a significant opportunity for future work. Thank you to everyone for listening. Thank you to my mentors, Dr. Patel and Dr. McCoy, as well as all of our clinical team and my co-fellows for all of your support over the past few years. Happy to take any questions.
Thank you, Lauren. That was fantastic. I think there's some questions that are coming through in the chat. If you want to unmute yourself.
Lauren, can you go over just briefly like the differences between some of the more commonly used tools?
Yeah, I mean, I think that most of them really encompass a lot of the same factors, right? So I think we're always looking at things like nutrition, polypharmacy, functional status, and it's really just which screening tool you use and how much it incorporates the patient. So for example, the G8 score, really, you don't need to have a significant discussion with the patient. A lot of it is, you know, when we go through it, is stuff that you're already asking or information you're gleaning as part of your routine visit. I think some of the tools do require patients to fill out more surveys, and I think those can be a little more cumbersome. So I think when we're trying to think about which screening tool to use, and the reason we are using the G8 score is because it's just, as far as we can tell, the simplest one and one of the easier ones to implement. But most of the scores at least are measuring similar things, just a little bit in different ways.
And it was also kind of striking to me, like the differences between the GI, you know, cohort versus the lung cohort. And I think it really goes to show that, like you had said, like the needs are different. Perhaps the timing needs to be better kind of reconsidered, but that was something I was not expecting to see, that, you know, that stark difference.
Yeah, absolutely.
There's a question in the chat, Lauren. Do you have a retrospective analysis for the PACT tool?
So I think our analysis, ultimately, we did implement this prospectively, but the analysis that we did was kind of looking retrospectively at those patients. So I think part of it, what we've done is the retrospective piece is really kind of seeing, you know, the outcomes for patients retrospectively. The future directions will really be looking prospectively at after patients who were then screened positive and then had implementation of a conversation, kind of how they did with that, and there more to come on that down the road.
Yeah, thank you, Lauren. My mic wasn't working at that time, but thank you for the reply. I only asked because I mean, as I wrote in my question as well, retrospectively, you can get a much larger cohort even outside of Illinois, and that would provide more robust data in support of the PACT tool. It definitely is a very interesting way of combining geriatric oncology with the standard of care techniques. So I really appreciate your talk, and it was very interesting. Thank you.
Thank you. Great points.
Fantastic, Lauren. Thank you very much. I think in the interest of time, we'll switch over to Dr. Altman. Really fantastic job.
Thank you.
Lauren, that was wonderful. Thanks for sharing that with us. Good morning, everyone. It's my pleasure to introduce Dr. Yazan Numan. Dr. Numan attended college and medical school at Heshimite University. He completed a leukemia fellowship at MD Anderson and residency at Marshall University. We were then lucky that he decided to complete his his fellowship at Northwestern, where he's been exceptionally productive, and I've personally been lucky to be working with him from the beginning. He has not only been a wonderful clinician, but has had multiple teaching awards, both from the residents, and has been inducted into the FAME Society. He is currently one of our chief fellows. He has also been able to demonstrate his academic achievements through being accepted to the ASCO AACR Clinical Trials Writing Fellowship. He recently had an oral presentation at ASH and received an Abstract Achievement Award for that. That work on FLIP3 mutated acute myeloid leukemia will also serve as the basis for his presentation today. Thank you, Dr. Numan.
Thank you so much, Dr. Altman. I hope everybody have a good morning. I have no conflicts of interest. So to keep my presentation simple, these are my outlines. I'm going to talk about the introduction, epidemiology, and incidence of AML, and the approaching for the treatment of AML in the area of precision medicine. And the most of the time I was spending talking about sequencing of FLIP3 targeted therapies. So as we all know, just briefly, that AML is the most common acute leukemia. The median age of diagnosis is 65 years old, and there's slight predominance in men and higher incidence in non-Hispanic whites. The latest data from this year in 2021 is published already. There's expected around 20,000 cases, and it will represent around 1% of the whole cancer diagnosis in the US. The estimated death is around 11,000, which account for around 50%. And the relative overall survival based on the old data from 2011 to 2017 is around 30%. However, we are seeing that the treatment for AML has been improving and improving overall survival. As you can see this nice graph that the overall survival for the patients since being diagnosed with the AML that has been constantly improving. We've been definitely lagging behind in the elderly population, but for people who are less than age of 50 and ages of 50 to 64, we've been seeing the upward trend, and that's very exciting time for a leukemia clinician such as myself to be treating AML. The most important development in the research of AML, in my opinion, was the characterizations of the mutational landscape for AML. This study published by Dr. Papa Manuel from New York showed that the AML patients have recurrent characteristic mutations. The most common are FLIP3, NPM1, and DNMT3 mutation, while there is a whole spectrum of these different mutations all over the place. As you can see, over around 200 mutations being reported in that study. This has led to incorporation of the mutational landscape into the prognosis of AML. And as you can see, the latest ELN classification incorporates the mutational landscape with the cytogenetics, which was the only prognostic factor that we used at the time back in 2010 or so. So the classification of AML subsequently have been more and more complex as we learn more different mutations and more characteristic cytogenetic abnormalities. But what I'm going to be focusing on is the era of precision medicine. And this nice slide shows the progress that been happening in AML with all these different targeted therapies that shifted the paradigm of treatment from just simple 7+3 to all these different oral targeted drugs that have changed the treatment for AML remarkably. So the thing that I'm going to focus on today is the FLIP3 mutated AML, and the current paradigm for treating a patient with a FLIP3 mutated AML is if the patient is fit for intensive chemotherapy, is chemotherapy plus midostaurin, and if the patient is not fit for intensive chemotherapy, currently we have the hypomethylating agent with some sort of a FLT3 inhibitor that's being evaluated in different generations now. But in cases of the patient's relapse, there's the recent report by Dr. Pearl, which we can discuss in a little bit, where the use of gilteritinib has really improved the overall survival for these patients, keeping in mind that relapsed refractory AML has a very dismal and very poor prognosis. So the incorporation of these new targeted agents have definitely changed the overall survival for these patients. So to talk a little bit about the FLT3 mutation, so FLT3 stands for FMS-like tyrosine kinase, and this gene is located in chromosome 13q12. The FLT3 is a transmembrane tyrosine kinase receptor that stimulates the MAP-PIK3C kinase pathway, and this results in the cell proliferation, and hence the presentation for these patients with AML, usually a very high white blood cell count, circulating blast in the blood. This mutation is very prevalent in AML. It accounts for around 30% of AML diagnoses every year. And this mutation comes in two flavors, the FLT3 ITD, which is around 80 to 90%, and the FLT3 TKD, which accounts for around 10 to 20%. Over the past 10 years or so, there has been multiple FLT3 inhibitors being evaluated in early phase clinical trials, and most importantly in phase 3 clinical trials. The FLT3 inhibitors are classified as type 1 or type 2, and there's another classification which I'm not going to be talking about as the first generation and second generation. But mainly it depends on when the drug was discovered, and most importantly, where does the drug works. So for a type 1 inhibitor such as the sunitinib, midostaurin, these drugs work at the juxtamedullary membrane part of the ATP kinase pathway, while the type 2 inhibitors such as the sorafenib or quizartinib, these drugs work at the ATP binding site for these drugs. Now, there are a couple of landmark clinical trials for FLT3 inhibitors. So the first one that we're going to discuss is a study published by Dr. Stone in 2017 that evaluated the incorporation of midostaurin with intensive chemotherapy for patients with a new diagnosis of AML with a FLT3 mutation. And this study design, as you can see here, have evaluated midostaurin with intensive chemotherapy compared to placebo and intensive chemotherapy. These patients did receive consolidation with midostaurin and subsequently went into transplant, some of them at least. And as you can see here, that the overall survival for patients with midostaurin have really improved compared to the patients who received the placebo. And that resulted in the FDA approval, and the current standard of care for FLT3 mutated AML that's a new diagnosis is incorporation of midostaurin. Once the patient relapsed, as I said, the prognosis was very dismal. However, with the discovery of the new specific FLT3 inhibitor, the gilteritinib, have really changed the treatment. And this Admiral trial, published by Dr. Pearl in 2019, evaluated the gilteritinib single agent in relapsed refractory AML versus salvage chemotherapy, and it was investigator choice of four different chemotherapy regimens. These patients, the patients who received gilteritinib had an improved overall survival to 9.3 months compared to 5.3 months, and that was really exciting, and that resulted in the approval of the gilteritinib in the setting of relapsed refractory AML. However, the big catch for this study is that this study was running at the same time where midostaurin clinical trials were still enrolling patients. So a lot of, or the majority of these patients didn't receive any previous FLT3 inhibitor. They just relapsed after intensive chemotherapy and subsequently got enrolled into the gilteritinib study. So our question, or the main concern in the community was, what if the patient received midostaurin or any different FLT3 inhibitor? Do we still achieve the same response in gilteritinib? The main concern or the anxiety causing issue here is that you as a physician or the patient receiving some sort of a same class drug for a mutation that didn't work might be wasting the patient limited months that he has to live. And subsequently, we really wanted to investigate this question. So our question was very simple, is that does gilteritinib produces the same results published in this study in the context of prior FLT3 inhibitor? So AML is a very rare disease, as discussed, in around 1% of the population. So it was very important for us to create a multi-institution collaboration to evaluate this question. And our work was presented at ASH last year as an oral presentation. We were awarded the Abstract Achievement Award. So how we started, we initially started with a few cancer centers. I remember it was like 3 or 4 cancer centers, but subsequently we expanded our cohort to 13 cancer centers across the nation from east to west. We got the IRP approvals and the data transfer agreement. We screened around 450 patients, and we were able to include 113 patients from 13 cancer centers. And here's the inclusion and exclusion criteria for our study. The inclusion criteria being that the patient have FLIP3 mutation at diagnosis and at relapse, and a patient received a prior FLIP3 inhibitor and then went to receive gilteritinib, and the patient have a valuable response and disease characteristics at the time of inclusion in the study. The exclusion criteria is that patient receiving gilteritinib as a part of maintenance therapy without a history of relapse, patient receiving gilteritinib as a part of ongoing trial because we do not want to double dip and report other clinical trial results, and patient have a missing follow-up data. We defined the responses to be consistent with the Admiral trial. So the CR definition was the bone marrow regenerating normal hematopoietic stem cells and achieving a morphologic leukemia-free state, and have an ANC more than 1,000, a platelet more than 100,000, and a normal marrow differential of less than 5% blast. We have also the definition of CRP, which is incomplete platelet recovery, which is CR minus the platelet count of, or a platelet count of less than 100,000, and the CRI, which is the incomplete hematological recovery, where there is still residual neutropenia of less than 1,000. And we, as the Admiral trial study did, we combined all these 3 responses into a CRC rate. We also looked into the MRD state of these patients. And the reason why we wanted to do that, because a lot of these tests are being ordered by the clinicians outside of a research perspective. So we really wanted to provide a real world data information about these questions of whether gilteritinib produces an MRD negative state, whether it's by flow or a PCR. And here is the definitions for a negative MRD by these 2 techniques. So here's the patient characteristics. Let me just move this here. And as you can see that the mean age is around 58 years old with a range of 18 to 92 years old. The majority of these patients were females. Something that I really want to point here is that I was really surprised to find that only 11 patients were African-American. That's included from a 13 cancer centers. So there is really an underrepresentation for the African-American population, whether it's in these retrospective studies or in the clinical trials. Something that we really have to be very conscious about, since we really want to know how these patients do respond to various therapies and how their disease characteristics might differ from the other patients population. The AML risk stratification, we had kind of like a first split between low intermediate risk stratification versus high, and we did have the majority of the patients have ITD mutation, while a very handful of patients having a TKD, but 9 patients did have both mutations at diagnosis. The majority of the patients, as we expected, received midostaurin as a part of their first FLT3 inhibitor, but there are some patients who received sorafenib or other FLT3 inhibitors that are still being evaluated in early phases of clinical trials. We did have patients who received transplant before and after gilteritinib, and we'll talk about the significance of this. And the response of the frontline FLT3, we had patients who relapsed on a FLT3 inhibitor, but we also have patients who were refractory to start with on the FLT3 inhibitor before enrolling into the gilteritinib study. The exciting thing about this data set is that we were able to collect the molecular landscape for these patients at diagnosis and at relapse. And as expected, the DNMT3A and NPM1 mutations were the most common co-mutations associated with the FLT3 mutation. What was interesting for us is that once these patients relapse after receiving a prior FLT3 inhibitor, we did see a slight change in their mutational landscape, while the WT1 mutation, for some reason, have really expressed in this population. But we also saw that NRAS, ASXL1, and RUNX1 mutation which are all these are poor prognostic mutations, have also increased. Now, taking you to the results of this study. So being a real-world data, we really wanted to see how long these patients stay on gilteritinib outside of a clinical trial context. And we report that around 5.7 months is the duration of treatment for gilteritinib, which is something very important to kind of tell the patients kind of when to expect a response and how long will they stay on this medicine if they're achieving a response. So that's something really important to report. We report the CRC rate for this cohort around 51.4%, which is slightly higher than what's reported in the Admiral trial, around 34%. That's something, again, we're reflecting a real-world data information here. It is a retrospective study, so it kind of different from a very regimented assessment for an Admiral clinical trial. And the CRC rate for the specific population that we have a great interest in, which is the patients who received 7+3 and midostaurin and then relapsed with or without consolidation. The CRC rate was actually slightly higher, which is around 58%, and their overall survival was around 7.8 months. This is something really exciting to report, as these patients really have the main question for the patients who received midostaurin and then relapses. They want to know what's their chance of achieving a CRC rate with gilteritinib using the same class drug, or I mean a newer generation drug, but same mechanistically working drug. So that's something really important to report. We did find that the patients who received stem cell transplant after receiving gilteritinib had improved overall survival. And we looked at the different overall survival states based on the CR, CRI, and the non-responsive. And we, as expected, we found that the patients who achieved CR had the highest overall survival. And out of these patients, the patient who achieved a double negative MRD state by a PCR and flow had 100% overall survival at around 2 years mark. So that's really something exciting to report, that MRD does really associate with an overall survival status. So since we have this very valuable mutational landscape data, we decided to look into every single mutation. And we found, as expected, that these patients with TP53, ASXL1, RUNX1 mutation have a poor prognosis. However, it didn't really affect that if they were mutated or not for the patient receiving gilteritinib. They all had a similar overall survival. But what's something really interesting, and it's something that's been previously reported mechanistically, is that mutations in the MAP kinase pathway, which is the downstream signaling for the FLIP3 mutation, or for the FLIP3 mutation in the kinase pathway, these mutations would likely result in a FLIP3 inhibitor resistant outside of a mutation in the receptor itself. So we decided to look into that, and we looked into the two mutations that's involved in this pathway, the NRAS and the PTPN11. And we reported that the patients who have one of these two mutations or two of these mutations have a much worse prognosis compared to the patients who didn't have any of these mutations. So that's something really important to report, as it will affect the future clinical trial design for different gilteritinib studies, that being very cognitive, that these mutations are likely not to be responsive to gilteritinib, and maybe a different treatment strategy should be considered for these patients. So in conclusion, gilteritinib remains clinically active in patients receiving a prior FLIP3 inhibitor. This is noted especially in patients who achieve CR and the patients who achieve an MRD state, especially double negative MRD state. The overall survival benefit stands regardless of the transplant status. And for a typical patient who remained refractory or relapsed on the standard of care treatment right now, the 7+3 and midostaurin, gilteritinib produces a CRC rate of around 58% and an overall survival of 7.8 months. And finally, the mutations that affects the MAP kinase pathway, such as the NRAS and PTPN11, have a lower response rate and a poor overall survival. We did submit our paper to Blood Advances, and we heard back from them last week. They requested some changes, but we're very confident that this work will be published hopefully soon. So just to close in, this multi-institutional AML consortium has been really a success for us as an institution, and also for us as fellows, because we've been able to have access to these large data sets asking these different clinical questions. And we're lucky that this year that we have an oral presentation at ASH with comparing the outcome of the Vyxeos or the CPX351 compared to other HMA venetoclax. And I know my co-fellows also have access to this database, and they have an oral presentation, I think, as well. We also are looking into these rare leukemias that we're not been able to study as a single institution, such as this acute erythroid leukemia. And lastly, we hope to use this multi-institution collaboration to conduct collaborative translational studies where we collect samples from these different institutions and do these translational studies in the lab. All right, so I want to close my talk with a picture from my home country, Petra, the pink city as they call it, and I'm happy to take any questions.
Great. Thank you, Dr. Numan. That was beautiful. As people are thinking about their questions, I would like to commend you for an excellent talk, and also ask if there are further questions you have regarding the FLIP3 studies. You've talked very nicely about the consortium you've developed. Are there things that could be better answered with more patients? Despite you having a large patient set, you're still at only about 113 or so folks.
So I think two questions that come really to mind. One is that providing a very predictive assessment for FLIP3 mutations, such as looking at the whole mutational landscape and also the cytogenetic abnormalities, and provide a comprehensive analysis for FLIP3 mutated AML, and kind of come up with a prognostic scoring system, for example, and kind of like have it for specifically for the FLIP3 mutated AML. The big question that we run into is the transplant for the patients who have low FLIP3 variant allelic frequency ratio and have an NPM1 mutation. Should we transplant those patients or not? It's really right now it's not known. So that's something that really we can look into that and maybe provide a very good answer for the kind of like the all leukemia clinicians that keep asking this question. So a lot of opportunities to look into this data set.
Excellent. I see a question from Dr. Chandra revolving around does the BRAF mutation play a role in acute myeloid leukemia? And are there efficacy differences between type 1 and type 2 FLIP3 inhibitors?
So the BRAF mutation, for some reason, is not that common in AML. I have a very limited experience, obviously, but Dr. Altman, you can also provide some input, is that we don't see that mutation very commonly mutated in AML. It definitely part of the MAP kinase pathway, so it might affect the resistance for FLIP3 inhibitors. I would expect so, but I really think it's a very rare mutations to be able to comment on it. Do you agree, Dr. Altman?
I agree completely. We don't know the role in acute myeloid leukemia, and there are very few patients who have BRAF mutations, as opposed to something like hairy cell leukemia, where it's seen nearly 100% of the time. Mm-hmm. And I think Dr. Chandra's second question was, could you comment on the differences between type 1 and type 2 FLIP3 inhibitors?
Sure. As I said, mechanistically, these drugs kind of work in a different binding sites for the FLIP3 kinase. The type 2 FLIP3 inhibitors are more specific in their binding. They have slightly higher efficacy, being gilteritinib compared, for example, to midostaurin. But also, having said that, these type 2 inhibitors are more selective and have a more tight binding to the FLIP3 receptor, while type 1, such as midostaurin, is a non-selective or non-specific tyrosine kinase. So it does bind to FLIP3 and c-KIT and other kinases that might result in these side effects and slightly decreased efficacy.
Thank you. It might also be worth mentioning that some FLIP3 inhibitors work to target the ITD and the TKD, but some just the ITD. Do you want to comment on that as well?
Yeah, absolutely. So the mutation, as I said, the structure of the mutation, the TKD is actually a point mutation in the receptor, while the ITD is an internal tandem repeat, where there is an excess of transcription of certain amino acids that change the structure of the FLIP3 and result in this constituted activation of the tyrosine kinase receptor. The midostaurin, for example, works for FLIP3 ITD only. However, the gilteritinib drug works on both TKD and ITD mutations. Sorafenib as well works in both mutations, if I remember it correctly.
Great, thank you. Dr. Gupta, did you have a question?
Yes, thank you. Yes, that was a very, very interesting and excellent talk. Thank you for that. I wanted to know is just for information, do you also plan to have some sort of a trial as a combination with for gilteritinib with, for example, trametinib, which is a MEK inhibitor to target the MAP kinase pathways?
So the mutations in the downstream pathways for the FLT3 are relatively rare. So conducting a clinical trial evaluating or overcoming the resistance for these FLT3 inhibitors will be very hard to conduct. However, having said so, again, the mutations in the MEK and the BRAF, the mutations in these two proteins are rare. We don't actually see them. We actually see more NRAS, KRAS, and the PTPN11. And unfortunately, right now, we don't have any drugs targeting these. But studying the MEK inhibitors or the BRAF inhibitors will be very hard to conduct, since first, this is a very rare disease, very rare mutations in that disease. So I think it's very hard to be able to be studied in a clinical trial setting.
Yeah, absolutely. Thank you.
Because on those are great points. You know, Dr. Ackland, Dr. Platanius, many others at our institution have spent their career studying the MAP kinase pathway. I don't know if Dr. Ackland wants to mention anything.
Yeah, we actually had a did a study many years ago, or tried to do a study with a SHP2 or PTPN11 inhibitor in MDS. And that was based on work in the lab. There is some interest in those drugs, and there are some that are around that are general to SHP1 and SHP2, both of which are involved in hematopoiesis, and some which are just SHP2 specific. And that's a sensible target, but it's one that hasn't been pursued that much.
Were these patients are FLT3 mutated as well, or I think if they're MDS, I don't think so.
No, they were not FLT3 mutated, but SHP2 is activated by multiple mechanisms in hematologic malignancies and myeloid malignancies. There are some mutations that are found that are acquired mutations in the PTPN11 gene, which makes it constitutively active. And then multiple of the cytokine receptors activate SHP2 also. And so anything that gets signaling going through those receptors, such as the FLT3 mutation, can involve that pathway also.
Interesting.
There's
Right.
been there was a lot of work on that in the context of FLT3 by Becky Chan down at Indiana University. She and her collaborator, whose name is escaping me right now, I have been looking at that, and they, I believe, had worked with the folks at Indiana in screening and chemistry to identify SHP2 inhibitors. They were interested in it because this is also the gene that's mutated in JMML.
Interesting.
Great. Thank you, Dr. Ackland. I want to thank everyone for being here today. In the interest of time, unfortunately, I think we need to cut off our conversation. Dr. Numan, outstanding talk. Thank you for sharing all that with us. Likewise, Dr. Chiec, thank you for sharing your expertise with us today as well. Hope everyone has a great rest of the day and a great weekend.
Thank you so much.